Hi, everyone, and welcome to our webinar. We're very excited to see so many people joining this webinar. We're just going to give it a few more seconds for everybody to join. But my name is Felicity Brown. I'm working at UNICEF and a co-chair of the MHPSS for Children and Families Thematic Group in the IASC MHPSS Reference Group. We are delighted to kick off this year's season of our Wednesday webinars for Wellbeing program with the first webinar, which is Caring in Crisis, Centering Children and Families in Mental Health and Psychosocial Support. So I just ask you, we'd love to hear from everybody, but because of the large numbers of people, we'd just love you to introduce yourself in the chat. Just let us know your name and your organization and where you're joining from. Marie, if we can click to the next slide. So my colleague Marie Dahl is the other co-chair of our thematic group, and will be doing the behind the scenes tech work for us all today. So as I mentioned, this is our first webinar for 2025, Caring in Crisis, Centering Children and Families in MHPSS. We have four amazing presentations for you from different organizations. I'll introduce them as they come up. And we also have other colleagues here as moderators to help answer questions and input as well. So as you can see, it's a collaboration between the MHPSS Collaborative and UNICEF, as well as Terre, World Vision, Save the Children, and Action Against Hunger. So just a little bit of housekeeping. Because we are a large group, we just ask you to keep your audio muted, and you can have your camera on or off, whichever you prefer. We would love to have your questions in the question and answer time, so please feel free to add them in the chat as they come up, and we'll try to collate them and post some live in the Q&A at the end, or presenters might be able to answer you during the webinar as well. And just a reminder, this webinar will be recorded and it will be available along with the previous webinars on the MHPSS Collaborative website and on YouTube, and you'll receive the recording as well as the slide deck at the once the webinar is finished. Marie, next slide. So the agenda for today is a quick introduction. So Relinda Reifers will lead us through that with some introductions to key guiding frameworks for our work. We'll have 4 case examples from Gaza, Mauritania, one from Ukraine, Burkina Faso, and Central African Republic, and Uganda. At the end, we will have a Q&A session, and at the end of the hour, we will also invite you to stay on for a more informal coffee chat where we can network and share experiences at the end. So that we'll keep the Zoom link running for another 15 minutes. And with that, I will hand over to Relinda.
Thank you very much, Felicity. Good morning, good afternoon, good evening, everyone. Delighted to see you all here. As Felicity mentioned, we have a couple of wonderful examples from the field. And before going there, we would just like to set the scene with some frameworks where we are working from in the field of MHPSS. Starting with the socio-ecological framework, which views children within the context of their families, communities, and wider society. And it acknowledges the role that each of those play in the life and the well-being of children. So when we design programs, it's very crucial to take all those different parts of the socio-ecological framework into account. Next slide, please. We also work from the stages in life course approach. So acknowledging that from a child, when it's very small, even before it's born, until it grows up, there are different protective factors and risk factors that we need to take into account. And they all also deserve our attention in designing and implementing programming. For example, I have an example here. So when a child, even before it's born and also in its infancy, parenting interventions can either mitigate the impact of adverse family circumstances, which results in children experiencing early life stress that can later on lead also to mental health problems in their lives. But at the same time, when there is a protective environment, a supportive family, this will also very much impact their well-being at the very moment and also much later on in their lives. Next slide, please. So, especially in humanitarian settings, an accumulation of different risk factors can be a strong predictor of poor outcomes of mental health and well-being. And hence it is crucial to identify children who face a number of different risk factors and see from those different angles how to best support them, and never work in isolation with your interventions, but really see different risk factors that can be faced by children and their caregivers, and work together to come up with a plan and implement the programming from taking into account all those different risk factors. Next one, please. So multi-sector approach, also very crucial. As we all know, it's at the humanitarian sector, MHPSS is really a cross-cutting theme. So if we work from different sectors and with different sectors, we can have much more impact on the level of mental health and well-being. And so child protection, healthcare, educational programming, that was I was looking for. They all are important to take into account with MHPSS programming and vice versa. So a very important toolkit to use for this is the minimum service package on MHPSS, which we will also share later on, and which gives really a helpful set of tools to create a single easy-to-follow intersectoral package with different actors. Next slide, please. The nurturing care framework. So that notes really the need for a multi-sector approach, including mental health and psychosocial support, and provides entry points for policymakers, for communities, for multi-sectoral support to vulnerable groups. Next slide, please. The MHPSS pyramid of interventions, many of you will know, but it really represents this continuum of care. So a multi-layered system of complementary supports that can meet the mental health needs of different people and groups. And this pyramidal shape demonstrates also the typical proportion of people who will require certain supports in a given context. And if we will see shortly that the presentations that you will hear from now, our presenters will highlight where the activities fit in the MHPSS pyramid, but also in the socio-ecological model, the child family community system, and the life course. And this will help us also to see the whole picture of how all these examples link to the frameworks that we are working from in MHPSS. Over to you, Felicity. Thank you.
Thanks so much, Rolinda, for that great overview of the different frameworks guiding our work. So this webinar really came out of a request for us to try to highlight, okay, we have all of these frameworks now, which is showing great kind of improvements in the maturity of our MHPSS thinking and the different frameworks that we now have to guide us. But there was a request to really show how do you operationalize these frameworks in an emergency, and what are some examples of how this work can really be done. So the different case examples are selected to try to give you some clear examples of this in real world practice. So I'm delighted to introduce the first case example, parenting in balance, multi-layered caregiver support in Gaza. So Rania Samour from UNICEF State of Palestine is going to present, along with Johanna Cunningham, our MHPSS specialist in the MENA region. So this presentation is focusing there on the family level and at different layers of the pyramid, mainly layer 2 and layer 3. So over to you, Rania.
Thank you, Felicity. Good evening, everyone. It is a really pleasure to welcome you all today. Thank you for joining us and for making the time to be part of this important session. We have a great group with us, and I'm really looking forward to sharing the ideas, learning together. So please feel free to engage, ask questions in chat box. So let us start. So today we are going to present parenting imbalance. And actually we have lots of activities related to the caregivers, but we are going just to speak a little bit about the highlighted books, which is brochures for caregivers and parenting between WASC. Next, please. We did a focus group for the children who their parents benefited from parenting imbalance program. And we found that we have like a great feedback. We can take 1 or 2 statements. Some of the children say that we feel better when they say things like, I'm around, don't be afraid. We are here, don't be scared. And also we have another example for WASC children who say that my aunt helped me, advised me, and cares about me. Next slide, please.
Thanks, Rania.
As UNICEF, yes, Johanna, please.
No, go for it. Thank you. I was just because I was with the organization when we were doing this part before Rania came and joined us. But based on those conversations with children, we wanted to try to make sure that our messages to parents were really reflecting what the children were saying mattered to them. So we based it on the MHPSS message bank. The content that we were adapting slightly. And we were also getting a lot of feedback from caregivers about some of the concerns that they had about finding some of the self-care strategies impractical in a severe crisis, some of the guidance around stay safe, some of the guidance around have a good night's sleep, make sure that you're hydrated and well fed in severe crises. Parents are very, very, very aware that this is not possible for them. So on the basis of the focus group discussions with the children, we adapted the messages to really focus on what the parents were already doing that the children were enjoying. Just these elements of saying to them, it is actually really important when you spend time together, when you say, I'm here, when you say to them things like, we don't have all the answers, we don't know what's going to happen, but we're going to try and stay together. Or if, to encourage them also to improve these messages, or to say that, just simply hugging, singing, praying together is helpful. These are the things that are having an impact. So it was also, we included simple psychoeducation on common traumatic stress responses, because we found that parents were becoming very concerned by some of the reactions that their children were having, even though these reactions we know can be normal in a severe stress state. With recommendations for things to do when there's not a lot of space to do them, and links to national helplines and other service providers. So this was a really important component of the messages that we were sharing. Back over to you, Rania. Thanks.
Thank you. Next, please. Caregiver consultation. So we did a consultation for the caregivers, and we find that they have lack of confidence in responding to the behaviors of the children, especially during the stress, and also inadequate time due to the severe lack on basic needs and the ongoing daily work that's needed to be done by caregivers. Also rupture in family dynamics, because we know in Gaza war, lots of family, they lost, the children lost their caregivers. And also when they separated between North and South, there was like a real rupture in the family. And also the caregiver also, they were aware about the cost, because the cost was so high for the children who came to their family. And also they have many significant concerns about sustainability of the care. So also the caregiver were aware of, they have lots of challenging between caring of biological children and WASC children, and it was something not easy at all. And parentings, they have like lots of roles. They tried to have the mother and father role to the children, and shifting some of these roles for the siblings because the life totally changed here in Gaza. And they have heavy sense of guilt because sometimes they felt that to taking the role as a caregiver for WASC children and even for biological children in such stressful situation is something very difficult. Next, please. But the good thing that caregivers reported a strong traditional and moral reasoning. Some of them say that they are my brother's children, and rejecting this responsibility was never an option. So still the caregiver, they felt that they are responsible for these children who lost their caregivers, and they would like to provide them with good care during this stressful situation. Next, please. Parenting in between TOC, which is a theory of a change. So we try to do many things for the parents. We try to provide them with and acknowledge them. And by this way, the personal and cultural strength can increase for the caregiver. And also we try to help them to explore and understand thoughts, feelings for themselves, and in the same time for the children, especially during a traumatic experience, to enhance good and effective positive caring for the biological and WASC children. And we try to equip them with attachment-focused strategies for communication and trauma-informed care. So we are trying to provide them with different exercises that's provided for the parents or caregivers who are having biological children or WASC children. Next, please. So we provided 8 sessions for the counselors who are providing these sessions for the community. And each session has its own specific theme. So we can take an example as first session, which is taking care of myself, which means the caregiver. So the caregiver need to take care of himself or herself before providing the care for biological or non-biological child. Next, please. Parenting in balanced structure. So it is an 8 sessions that's focused on holding balanced relation to caregivers' concerns for age 7 to 12 and also 13 to 18. And also in addition to that, we have in each session like around 45 minutes for a session which is related or focused more on WASC children and facilitators guidance and the training for the counselors who are going to provide these sessions for the parents or caregivers in the field. And also they have supportive WASC brochure and broadcasts, radio spot. Next, please. So we trained 13 staff members successfully in Gaza, and 11 staff of this staff, they did piloting sessions. So each one provided one group of 8 sessions, and they start to have many different feedbacks from the caregivers. And we found some positive and some negative feedbacks. So by this way, we can adapt our curriculum and also our parenting imbalance manual that's to be enhanced and adapted to Gaza, especially during the crisis period. Next, please. And we found that caregiver greatly benefited from sessions by learning practical strategies to manage challenging behavior with empathy, because they start to control their emotion and to do some relaxation, and they use the MHPSS techniques before providing any session to the children or to either to biological or non-biological one. And after that, they focused on building skills in emotional validation and strengthening connection with their children. And we focused here on attachment. So we have many activities. As I said, we have 8 sessions. And in each session, we have full package of activities, which is applicable to each theme in each session. And through a role-playing exercise based on real-life scenarios, participants were able to practice a new approach in safe space. So each one starts to exercise some activities, and also they provide each other some examples and some experience about caring for biological and non-biological children, and what the difference between both type of the children and what activities to be provided. And the sessions also provided available opportunity for peer learning as caregivers shared their personal experiences and support one another in a welcoming and supportive environment. So they start to support each other in good way. Next, please. They found that 2-hour sessions duration was too long for caregivers, especially or particularly in this difficult circumstances and the stressful situation, because as we know, that's all people in Gaza, they are searching more on their basic needs. So sometimes they find difficulty in managing 2-hour session. And there is several limitation in supplies entered to Gaza, which limited printed resources and items needed during sessions. Next, please.
And we've just got 1 more minute, Rania.
Yes, so the final or next steps that to be done for the caregivers is to expand the reach of this program in all Gaza and to reach to the community. So by this way, we can reach to the caregiver who are caring for biological and non-biological children, and in the same time explore and continue to explore and impact the program learning with caregivers and prioritize children or caregivers who having WASC children, unaccompanied and separated children, support them in this difficult circumstances. Thank you very much for the time.
Great. And so then from, our key recommendations for parenting support in crises is to really acknowledge, as Rania has been saying, to really acknowledge what's being done and what is working and what children are saying that they need. So making sure that we're not giving families more of a list of things that they need to be doing, things that they should do, but to really sort of provide them with space to talk about how what you know as a parent and the way that you love your children has been challenged by this crisis. So I see Maria's asked a question in the comments too about that. And it's, so that's why we're calling it parenting in between. It's in between taking care of yourself and in between giving care to others. It's parenting in between, in balance with, having empathy for children's behaviors, but also being able to set boundaries and rules so that the family can come together. It's about managing these conflicting and competing values. How do you be the parent that you want to be and that you know how to be when the situation around you is preventing you from doing that? And so there's a lot of emphasis on having time and space to come together as a community and to be able to talk through these values and to talk through these approaches. So in the interest of time, I'll stop so that we can hear from our colleagues and we could come back to some of these if we need to.
Thank you so much. Thank you so much, Rania, and thank you so much, Johanna. And Rania, especially thank you for joining us from Gaza. It was really amazing to hear your work, sort of truly contextualizing evidence-based approaches to meet the needs there, and a true participatory approach to designing their interventions. So thank you so much. There's several questions in the chat if you have time to answer them now, but we'll probably bring some up live in the Q&A as well. So I'm now going to move over to our next case example where we have Lamine Decour from Terre joining us, the West Africa Regional Child Protection and MHPSS Technical Advisor, presenting on their work in Mauritania. So MHPSS Emergency and System Strengthening Dual Approach. So we're shifting now to thinking about how we strengthen the systems around children and their families across the different layers of the pyramid. Over to you, Lamine.
Hello, everyone, and glad to be here. Thank you, Felicity, for the introduction. Thank you. I think you can go directly to the next slide. So I will start to introduce the context. So since 2012, the crisis in Mali has triggered a large influx of refugees into Mauritania, especially in the region of the head of Charlie. Recently, the overcrowding of the camp has led more and more refugees to settle in nearby villages. Over 138,000 refugees are now living outside the camp, putting additional pressure on already very fragile areas with very limited resources. After more than 10 years of ongoing emergencies, the limited impact of short-term humanitarian response and unequal access to basic services push both donors and also national authorities to rethink the paradigm. They shift from a direct emergency response strategy to a system strengthening approach, aiming to make the system functional, more efficient, and more inclusive. The goal is really to build a system capable of meeting all needs, including those arising from the arrival of refugees. Next slide, please. Thank you. So TDH has been working on Mauritania for over 40 years, starting with health intervention and later on expanding to access to justice, migration, and strengthening the child protection system. For many years, TDH has, through local partners, also support cross-cutting MHPSS intervention for both children and adults, mainly at level 2 and 3 of the pyramid. In the Hodel-Shagi region, the emergency context and the availability of funding create a new opportunity to strengthen the existing system. This is why TDH has proposed an intervention aimed at reinforcing both protection and MHPSS system based on the following key reason. Next slide, please. So TDH conduct an need assessment which highlighted several findings. The first one is that mental health and psychosocial support remains largely overlooked by most actors. Very few organizations work in this issue, and when they do, it is mostly part of the other program like child protection, SVBG. So there is also a clear lack of data on MHPSS, making it difficult to have an overview of the situation. For example, some organizations make some child protection need assessment without including any question on MHPSS. So it was very, very difficult and challenging to have that overview and to have some data. At the same time, all stakeholders we met, without exception, when we put Thematic on the table, consider MHPSS as a major and not cover need. So discussion with communities confirm the scale of the needs and reveal the many different forms that psychosocial distress can take. So finally, we notice growing interest from donors in MHPSS, especially when the framework is when you are proposing something that's kind of continuum of care, they are very interested by the mental health, but also the psychosocial support to really have, both of them and just not move forward with health actor on mental health, on protection, on psychosocial support. Next slide, please. So based on that constant TDH frame of project funded by AFD and also by Union European. So the slides show the main action taken to build a strong MHPSS system and at the same time to respond to the urgent need of the population. The two components are closely interconnected and mutually reinforcing. Emergency activities help improve the system in the long term, and system building efforts stay connected to what is really happening on the ground. That is very interesting because that means that the children, the families, the communities also have the capacity and the ability to influence, the politics, the framework, and also, the national strategy. This dual approach enables a more integrated, effective MHPSS response, And when I was doing that slide, it was a little bit complicated sometimes, to put some action in humanitarian response or system strengthening, because a lot of them are really like cross-cutting and transversal. Next slide, please. So with this approach, with this dual approach, while this approach brings a lot of benefits, it's also involved a lot of challenges. In terms of challenge, we must respond quickly to urgent needs while working to build a sustainable long-term system. So through efforts that often operate on different timelines. I think it was the first and the main challenge, for us to say, okay, what we should prioritize. There is also limited expertise available to implement standardized intervention, as PM Plus is, and that kind of intervention. And in some areas, formal systems are almost non-existent. In addition, there is often a lack of national guidance or leadership, especially from key ministry responsible, to lead the system. This is the Ministry of Health and also Child Protection. Despite these challenges, the dual approach creates valuable opportunities. It allows to build a national system based on real needs and existing practice, and to strengthen the capacities of relevant ministry over time. It also supports the development of a shared MHPSS roadmap involving both institutions and communities. Most importantly, this approach ensures that the interventions are relevant and sustainable in the long term. Next slide, please. Thank you. So, situation analysis. We just want to highlight the importance of carrying out a deep situation analysis with a good approach. For us, it was the first activity of the project. So how do we do that situation analysis? So to address existing information gap, the idea for us, the main goal for us was to address so we already collect a lot of data, a lot of information. So to address existing information gap, we use for the interagency, multi-sectoral MHPSS need assessment toolkit, combining qualitative and quantitative tools. This requires strong contextualization. So that means it also requires some time and resources to ensure that the tools were adapted to local realities. The process was supported by external MHPSS experts, but given to the large volume of data collected, additional support from a data analysis were needed to ensure accurate and meaningful interpretation. Importantly,
One more minute, let me.
Yeah, thank you. The process was highly inclusive, involving host communities, returnees, children, adults, whose voices contributed to a more grounded and relevant understanding of need and available resources. So I will let my colleague Maria do the last one. What are my recommendation?
Yes, hello everyone. Just to share some of the recommendation, I think a lot are in line with what Lamine just said. One of the important recommendation is the importance of the in-depth situation analysis that is there really to help us gain, clear understanding of the local context, but also the services, the needs, the resources, the barriers, and that really helps in refining the best intervention. The importance of the intersectoral approach, especially when we look at strengthening systems, we know how much is key to work with health protection and other actors to have a continuum of care. Then, of course, data is playing an important role in actually identifying and grasping the importance of the needs and also monitoring the ongoing intervention and the impact of those interventions. So we really need also to have reliable data to help programming for long-term impact. In emergency context, as we've seen, adopting this dual approach when possible is really helping us to address immediate needs while also laying the groundwork for long-term system strengthening. So this is, of course, recommended whenever possible. We realize, of course, that is really depending often on the availability of funding. But I think that beyond the funding, it's also in the intention that we have when we build system for emergency to see what's going to be able to remain behind. And finally, just the last point, maybe emphasizing on the fact that, yeah, when we have this dual approach, of course, the idea is to start with emergency intervention at the different level, and also continuously continue to conduct situational analysis at those different levels to start really building long-term strategies and approach for system building.
Thank you so much, Lamine and Maria. It was really interesting to hear your critical analysis of this balance between responding quickly in an emergency and that focus on building systems. I think it's very timely as well at the moment with the shrinking funds and the humanitarian reset process. It's very timely to start to think through these challenges. I'm rushing a little bit because we are a little bit behind schedule, so I'm going to quickly hand over to our next presenter, Leah Ankankwasa from World Vision International in Uganda. And she's going to present their work in integrating early adolescent skills for emotions into protection systems in Uganda. Over to you, Leah.
Thank you so much, Felicity. Good morning, good afternoon, good evening, everyone, wherever you are. My name is Leah Kankwasa, and I work with World Vision Uganda. Yeah. Next slide, Felicity. Yeah. So, giving a little bit background on the conceptual framework on integrating early adolescent skills for emotions in protection and integrating it in the different protection sectors. Yes. We looked at the background of the children who are living in the crisis conflicted context, and then we're like, how can we contribute to the mental well-being of the children and their social well-being without affecting them? Realized that as World Vision, we were doing a lot of other interventions, but not doing mental health, and we're providing basic psychosocial support, but not intrusive psychosocial support. So when you look at the conceptual framework, we got the model, early adolescent skills for emotion, which is developed by World Health Organization, and integrated it into child protection, positive parenting, using the nurturing care group. You can pick a leaf from what was earlier presented by Johanna, and you'll see that integrating mental health in positive parenting gives you better results in mental health. So that is what the framework is all about, and that's how we manage to get our target on making sure that we achieve the results of the effect of the model. Next slide, please. Yeah, so this is the model I'm talking about, early adolescent skills for emotions. It has 7 sessions for the adolescents, and at the same time, it has 3 sessions for the caregivers. So we realized that this model gives you an opportunity to support the children, but at the same time, support their caregivers who are caretaking for them at home. So if you give the children the skills on using these different models, which is understanding my feelings, calming my body, changing my action, and managing my problems, you help them to adopt skills on managing the different issues they go through, what causes them distress, what causes them anxiety and depression. But then they cannot achieve all this if their caregivers are not given the skills. So when you look at the sessions that target caregivers, we help caregivers to identify also their feelings and understanding feelings of the children, and then on self-care, and then spending quality time with children. So in the background, I told us that when children are in the conflicted context, you find that they go through a lot of issues that affect them or cause them distress. And sometimes their parents contribute to the triggers of distress in the children. So this model helps us to build skills both in the children and then in their parents. Next slide, please. Yeah, so why is in Uganda? In Uganda, we have World Vision. We piloted this model in a settlement called Bidibidi Refugee Settlement, which is in Yumbe district, that is the West Nile of the country. And then we had a child protection caseload of around 1,850 children. So this model it targets children between the ages of 10 to 14 to 15 years. So it came out as a study. One of our colleagues was doing his PhD, and we piloted it in this settlement to see how effective it is if we integrate it into child protection. So we picked our case study from the child protection caseload that World Vision was already implementing using the different approach of child protection. So after doing the targeting, out of the 1,850 children, 653 were within the age group that we're targeting, that is 10 to 14 years. And then we assessed these children using the ARACADS tool, which is Revised Children Anxiety Depression Scale. So this scale is to measure anxiety and depression. So after conducting this assessment, which was done by our staff and the volunteers who were trained on the model, because the model can be implemented by people who are non-psychologists. So before we even did the assessment, we identified community structures and we trained them and the staff so they had the knowledge on how to use the tool. So of the 653 that we pre-assessed, 473 children were identified with symptoms of distress and of anxiety and depression. So of the 473 children, it means we engage them in the sessions. So when you look at the graph I'm presenting here, the pre-assessed, and then the children that qualified for the session, and then the ones that completed the sessions. So what do I mean by the ones that completed the sessions? It means these are the ones that obtained the skills, because after the session, after completing all the 7 modules, children, we do a post-assessment which shows us the level of improvement in these children. So you can see that from here, 457 children showed improvement in their mental well-being, which is very good compared to the number that was pre-assessed. Because in the pre-assessed, we have those ones that dropped out, that didn't complete, but the 457 children in BDBD, after being exercised to this model, they showed skills and are doing well in coping up positively and in managing their distress. Next slide, please.
And Leah, just to note, there's 2 minutes remaining, so we really want to hear your findings. So just,
Let me run through. Yeah, so I've already talked about this slide actually on how the implementation outline was done. Yeah, identification of the children and assessment. Then the key findings, still here, I'm trying here to compare the children after the study was done, an assessment was done, and we compared the two groups of those ones that were exercised to ease and the non-participants of ease. And you can see that there is an improvement in the children that did the sessions compared to the ones that did not attend the session. So here we're trying to show the effectiveness of the model and the effectiveness of these sessions in children. Next slide, please. Yeah, adaptation of this model by World Vision Uganda. So after it being piloted in the district that is hosting refugees, we went ahead and introduced it to the MHPSS sector working group in the BDBD so that they get to understand it and appreciate it, because it is a model that you can implement on low budget and that it can be effective. So another adaptation where we've done this is that we have trained over 16 staff as supervisors and coordinators of this model who can be resourced even to have it disseminated in the different regions in the country. At the same time, given the fact that this model addresses the second ladder on the pyramid, we also engaged community structures, and this is why I talked of the volunteers that we've trained. So we've trained over 18 volunteers. This is how we are trying to adopt this model into the country. Then also we've integrated it in child protection and livelihood. We do not implement it as a standalone, but we implement it alongside other models. Then we have also gone ahead to make sure that we develop more concepts of this model's effectiveness so that it can be implemented in other locations. Next slide, please.
And we're just 30 more seconds, Leah.
Yeah, so this one I've talked about it. This one I was trying to show us the effectiveness of the model when integrated in child protection and how we did it. We identified children and trained them as ambassadors who now got down and practice these skills with other children. It is a therapy for those ones that go through it. It is for them alone, but then the few skills we pick and then ensure that other children in the community learn how to practice these skills on their own. Next slide, please. Yeah, this is trying to show us here in how we integrated it in livelihood. We identified teenage mothers who were distressed, and then we gave them more skills on top of the therapy. We gave them skills on vocational skilling so that they can improve their livelihood and address the triggers of distress among them. Next slide, please. Yeah. So these are the early outcomes that we realized before even completing the whole study. We saw improved emotional regulation and stress distress, increased caregiver involvement and understanding in children's lives, and then enhanced referral pathways. So here, like I said, we don't do it alone. When we find that some triggers of emotional distress is caused by other factors, we do a lot. And when it is beyond the clinical scale for the model, we also refer for clinical support from the mental health other practitioners. Next slide, please. Yeah, so these are our next steps as our vision is to advocate for national adaptation of EASE because we have seen that it is effective and it is practical. Then also to expand to other locations, like I said, and then to strengthen the monitoring of the model using the WHO tools, and then to ensure ongoing training and supervision of other colleagues who are interested in mental health implementation. Next slide. As I conclude, so the key recommendations from our vision is to enhance community sensitization. We saw that community sensitization is essential in reducing stigma because we did it and we saw it were quality clinical supervision as facilitators is key. So here as World Vision staff in Uganda as we're implementing, we had that clinical supervision from our technical people and also the clinicians from the mental health lead partner. Then the need to invest in integration of evidence-based tools. Yes, this one also. Cross-sectoral collaboration and integration is essential for sustainability. But here it requires stakeholder advocacy. So this is the recommendation we are giving to every stakeholder to ensure that we advocate and we collaborate if we are to address the distress and emotional challenges children go through in the conflict context areas. Then intervention should not be a standalone. Like I said, we implemented it in child protection, in livelihood. So if you're to make it practical, if it is to be effective, you cannot implement it as a standalone model. Yeah.
Thanks.
Slide as I conclude.
Thank you so much, Leah.
So yeah, those are my acknowledgements. And Duke is the one who introduced the study in the region, and then the people that implemented, then Fiona, who was a clinical supervisor, and then Rambayo, who was the program manager. Thank you so much, Andoha.
Thank you so much. It's so nice to see the thinking around how this psychological intervention can actually be integrated alongside, broader systems of care rather than being a standalone intervention. Thank you so much for sharing your promising findings. I'm going to move over to our final case example from Suan Fan at Action Contre la Femme. Presenting on supporting children in psychological distress in conflict settings in Terre, Burkina Faso, and Ukraine. So this intervention is again focusing on the child, and it's between the layer 3 and 4 in the pyramid. I will hand over to Swan to explain more.
Swan, we can't hear you. Potentially, are you muted?
I'm sorry. I'm sorry, I was muted. I'm sorry. Yes. So hi everyone. So I was saying that it's the group a group protocol intervention that has been developed by Action Against Hunger for children in psychological distress. Next, please. So here, as you can see, there was the very first pilot that has been conducted in Central African Republic in 2016. It's evidence-based because it has been implemented along with research. And after that first pilot, it has been implemented in 6 other countries, in Chad, Iraq, Cameroon, Burkina Faso, and Ukraine. So the protocol, in a nutshell, is a 5-session protocol targeting children between 6 to 17 years old.
group intervention for a group of 8 to 10 children, and facilitated, so because it's between layer 3 and 4 of the pyramid, it can be either conducted by non-specialist psychosocial workers, supervised by psychologists, or if implemented at the 4th layer directly by psychologists, which is the case, for instance, which was the case in Iraq. Evidence-based because, so there was, as I said, so a first article published in 2019, and then this setup has been also compared with EMDR protocol, showing that there were the same findings in terms of improvement of well-being. That is, the article is actually in press, and my colleague Elisabetta, who is one of the authors of the article, is here, and she will be happy for the Q&A session to answer any further question. Next, please. So how does that work? We have like a screening with the psychoeducation session to see which children would need like further psychological support. Within the 5 session, it's based on the CBT approach and the narrative exposure therapy. And as you can see, it's mediated through drawings. So we let first the children with the drawing board to discuss and to see about what they can see about the story of here, the hippopotamus, Kono, it's his name. And then there is the whole story of Kono by the past, the present, and the future of Kono. So once there is the group discussion on the drawing board, we encourage children to have their own drawing, to draw about their life. And then after, in the group, we encourage them also to share about their experience so they can express their emotions, and then also discuss about what they experienced. So those are the different phases for each session, and we have 5 sessions. Next, please. Here, it's an example of the adaptation. So it has been implemented in 6 countries. There is the Kono protocol with the hippopotamus, mainly used in Africa. In Iraq as well, the protocol has been adapted. And here in Ukraine, what I wanted to share with you is that it has been adapted like the animal, because a hippopotamus wasn't very adapted to the context. So it has been discussed with the participants, and they have decided to use the dog, and his name is Patron, and it's based on the real story of Patron. So you can see it's Fox Terrier, I don't know, who is the dog from the Ukrainian army. Next, please. Here, I would like to share with you some findings showing that the protocol has a improvement of the well-being, and then helped reduce post-traumatic syndromes. So, for instance, here we use 2 tools for the pre and post-intervention: the visual scale based on the Wong and Becker faces here. The one we used is rated between 0 to 10. And then the CPTS-RI. And as you can see here, comparing the result from CAR and from Burkina Faso, they are quite the same, meaning that at pre-intervention for the visual scales, it was rated around 8 out of 10. And then post-intervention for CAR, and around 1 for Burkina Faso. And for the other scale as well, we can see that there is a shift between the severe to mild and light distress. Next, please. So for the the advantages of the protocol, it really offers like a very safe space for children to gather together, and it offers a kind of regularity in terms of follow-up. It can be between 1 or 2 sessions per week. It helps children to express their traumatic syndromes, to express their emotions through some visual aids. It also strengthens social cohesion through the positive dynamic group that can be established with the 5 sessions follow-up. And from the psychosocial and non-specialist perspective, it was mentioned that this structured protocol really helped them to follow up the psychosocial support for children. In terms of challenges, so there is, of course, like the contextual adaptation of the protocol, talking about the related to the language, the belief and perception of psychological distress according to each context, the security access to the location and to access the beneficiaries. Sometimes constraints because sometimes children, when they go to school, there is a need for adaptation of the proper timing to have the activities. And then, of course, people are on the move due to the conflict settings. So sometimes they are lost to follow up, or people don't come back. Next, please. So as a key recommendation, there are main recommendations, but it's really about emphasizing on the community mobilization for better engagement, to explain the purpose of our activity. Cultural adaptation is key. So we take a lot of time for the translation of the local terms, working with the community to see what is acceptable or not. And that's why we have like a several adaptation of the tool. To recruit, of course, staff who speak the local language for direct intervention. For the training is very important. It takes about 10 to 15 days with a theoretical background about what is a psychotrauma, very basic theoretical knowledge, and then dive into like the protocol per se, plus the clinical supervision. Identify, of course, a safe space to implement those activities, and then establish the group per age range with 1 or 2 staff. And I'm done. Within 9 minutes, I think.
Thank you so much, Luan. And yeah, it was really fascinating to hear about ACF's work at that higher level of the pyramid. Somebody pointed out quite rightly in the chat that it's challenging to have 4 case examples presented in one webinar, and I definitely agree that we could have had one webinar for each of these approaches for everyone to learn more. We were excited by all of the different things that we wanted to showcase in this webinar. So thank you all for sticking with us, and to the presenters for keeping your presentations concise. There are a lot of questions in the chat, so please go in and check if there are any that you can answer in the chat. And just to sort of tie things together, I think that some of the key themes that we heard throughout in terms of recommendations for children and families are related to the fact that conflicts really put an incredible amount of stress and take a lot away from children and families, and also providers and systems. So we heard about the importance of contextual and cultural adaptation, community engagement and participation, multi-layered and intersectoral approaches, using situation analysis and data analysis to inform work, and the importance of strengthening systems, as well as ensuring quality for providers. So next slide, Marie. We do have a list of resources here, and this slide deck will be shared with you so that you have these links. They were also posted in the chat, but please do go in and check this list for anything that you want to read more about. Next slide. We will keep the webinar running, as I mentioned, for 15 minutes. If you do have to run and you do have more questions, please feel free to reach out to presenters directly. Just before we hand over to Q&A, I will just also quickly go to the next slide. and remind you all that this webinar is the first in a series for 2025. Our next webinar will be in September, and we'll be focusing on child and adolescent participation and peer support in MHPSS. Another fascinating webinar where we'll be inviting different agencies to share their work with you. So thank you, a huge thank you again to all the participants for your active engagement in the chat, and big thank you to the presenters for sharing your work. I will hand over to Relinda now for the Q&A, and this is now the informal coffee chat time as well. So over to you, Relinda.